Okay, welcome everyone. Sorry we had a hiccup there with the password, so hopefully we'll fix that for next time. Um, we've got a fair amount to cover tonight, and we're going to be talking. We'll be talking a bit about. Let me just change this here for a moment. So we'll be talking a bit about a few different topics today. So school reopening and sort of some of the new data that's coming out about schools and kids and risk of transmission, um, and um, so what that looks like. And then we'll be talking about the prisons and what's going on in the prison system, and then some recent stuff that's been released around therapies, and what's happening with vaccines and other therapies like that. And if you could submit questions, please do it through the Q&A. That would be great. And if you guys could please just let me know that you can see me okay and you can hear me okay. If you can just send a little chat note saying yes to that as I proceed, that'd be good to know. Great. So let me go ahead and share some of these slides. And I think what I'd like to do is start with a conversation that really sort of lays out the epidemiology of where things are right now. As you know, in the past month, things have changed a lot. And so we'll touch on that first, and then we'll move into sort of the conversation about schools and should they be reopening or not, what that might look like. Then we'll talk a bit about the prisons and what's going on in San Quentin as one example. And then we'll spend a few minutes talking about emerging therapies. The one thing I just want to encourage, is why I keep it here as a daily practice, as best each of us can in the setting of what we're currently experiencing now with COVID. I really would encourage you strongly to have your own daily practice that keeps you sane and maintains your sanity, because I think the emotions are quite high right now, between what's going on with COVID, what's going on with the social justice, equity movement, and what's going on with the politics. We've got a lot, and we're all really taxed, and our resiliency is being really challenged here. So I really encourage you, if there was ever a time to take care of yourself, it's now. And if you can even spend 5 minutes, just 5 minutes a day, doing something that means something to you, or whether that be something that you enjoy as a hobby, or whether it be a meditation practice, whatever it might be for you that gives you some sanity, I really encourage that. I know for myself, I'm really trying to focus in on that, because I myself are feeling the same things I'm describing that we're all feeling. So I welcome that. So looking at sort of the globally, we know we've got a lot of cases now, 13 million. And we've got, just in the United States alone, 3.5 million cases, which is really quite phenomenal. We have 500,000 people that have died, 578,000. And we have really, if you look at the United States, it's far above everyone else. Clearly an outlier, and clearly as a result of the lack of federal and national leadership that we've had. And we'll talk a little bit more about that later. So if you then sort of hone in a little bit and try and look at emerging trends, what you can see here is that Latin America really at this point accounts for almost half of all global deaths. They're really being hit hard. And you can see the United States there making up 14% of the deaths, and that it's starting to rise again. You can see how that's growing, how we sort of, there was, the gray band started to narrow down, and now it's sort of starting to expand back out again. In Latin America, you can see on the top half, and we'll see as it rolls through Africa and India what that begins to look like. You can look at the Europe and how well they've done, and how well they've really done a great job thus far to date. So if you look at the United States, here's another way to look at it: cases by day with a 7-day moving average. If you look at the United States, you can see how we started, we popped up in March, April, and then we started trending down until about a month ago. And now all of a sudden we're really you can see it's a repeat, if you look at the slope of that, of what, almost the same slope, not quite, of what we had previously. But now you can look at how many cases we have. We're actually having more cases now than we've ever had on a 7-day moving average on a daily rate. Now, the difference is that President Trump has chosen to do a blackout, basically, on disseminating this information and trying to, in his attempt to try and become reelected, to pretend that these are just more cases and that's not resulting in anything other than we're testing more. And as we all know, that is complete false. That is what we call a myth. We call alternate reality. The truth of the matter is that there are more hospitalizations and there soon will be more deaths as a result. And the sad truth is that the percent positive testing is going up as we speak. So there's some good news on this. So it's not all anxiety producing, but I do want to sort of lay out the truth of the matter and shed that science, separate science from myth and wishful thinking, which President Trump has done throughout the duration of his tenure. If you look here, this looks at the reproductive number. And what that means is the rate at which the virus is spreading in a given community in this state. Is looking at state by state. And I have two different graphs here. The one at the bottom shows what things were looking like 3 months ago. The green means it's below 1, which means that the virus is reducing its spread. It's actually contracting. The numbers of cases are going down because it's less than 1, meaning that if I get infected, that I infect less than 1 person, which would then result in an extinguishing of the epidemic in that area. The upper graph was done yesterday, and you can see here, it was last updated yesterday morning, you can see everything's popped, excluding Maine, Connecticut, Rhode Island, Washington, D.C., South Dakota, New Hampshire, and Utah, which are all in the green. Everything else is now in the red. So this is sort of one view of what's happening. Another way to look at within California itself is we now have over 3 million cases in the United States. Actually, this slide is looking at the United States overall with 130,000 deaths. Now you can see that the cases are going up, and you're starting to see, if you look at deaths, that it's starting to climb up in the past 2 weeks. Each bar represents a week. And we're seeing primarily this is across the Sun Belt and also in the West Coast, primarily 20 to 40-year-olds, which are taking up a lot of ICU beds. There's less deaths because they're younger and healthier, but this 20 to 40-year-old group is actually taking up a lot of ICU beds at this point. And we can see is a 72% increase in cases nationally over the last 2 weeks alone, with 5 states setting single-day records. If you heard, I think it's the governor, of Alabama came out today, encouraging everyone to wear masks, saying it's their duty, if they love thy neighbor, if they love their family, and if they love thyself, I think is how he explained it when I heard him on the NPR today, you will wear a mask, please wear a mask. So finally, we're getting a lot of the Republican governors to finally see the light of day and to encourage social distancing and wearing masks. If you look at California, you see here the dramatic rise from sort of mid-June on at a 7-day average here. And if you look on the left-hand side, the darker brown colors are the areas where they have the most cases. It's 250 plus per 100,000 people. And this look is focused on just new cases. This data is pulled out of the Chronicle, so you can look at, there's other ways to tweak this data and look at different aspects. But you can see here there's very few counties that have 0 cases, but there are a few. You can see Marin County is one of the dark brown ones. And a part of that is related to the San Quentin prison outbreak, which we'll talk about. But even putting that aside, there's significant growth happening here. San Francisco is actually looking a bit better. And you can see sort of the surrounding area. If you look in Southern California, particularly Imperial, I believe it's called Imperial City, San Diego County, you can see huge issues there. With the opening of the border between Mexico and California, there's been bi-directional flow with people that are ill in California moving into Mexico, as well as people in Mexico that are primarily sort of expats that are coming to California to get care that are ill as well. So that's sort of the current situation. In the county by county, looking in the Bay Area primarily, you can see the weekly changes. Now, things are looking somewhat better in certain counties. Alameda County is an example, and San Francisco, San Mateo. But you can see, for example, Marin is up 21%. Napa has actually also gone down 35%. The number of cases are small. So the largest numbers that you can see there are, you can see sort of pretty clearly there. Well, Alameda, you can see, a reduction in 222 cases, which was nice to see. So as you know, there's been a rollback with restaurants and bars and encouraging, not indoor dining and closing of bars and really trying to roll things back to get more control on what's happening here. So let's just talk about Marin County for a moment. There's been a big surge, and part of it relates to, or the whole Bay Area really, is people are starting to relax, particularly young people who are not wearing masks and not social distancing, as well as adults that are older, that are just been quite a bit of a loosening. And as a result of that, we can see there's a big flare up. And so what we're hoping now is that people will start to sort of find the middle ground that we used to have. Not maybe quite as restrictive, but at this point, things are out of control and we do need to be really restrictive. And so I encourage everyone to think about that. An important piece of this is the predominant people that are being infected is really folks that have multiple people in their home and people that can't work from home. So those that can't work from their home and they're out in circulation, and then they come back to their home and they live with multiple people, other household members in their home, those people are at the greatest risk, and they have been the nightest of this increase. It happens to be associated somewhat with, culturally and ethnically, but that is unrelated to the biology of what's happening. The biology of what's happening is really a socioeconomic one that relates to household density and being required to be in circulation in society right now. So I encourage those people to sort of, and in the past 3 weeks alone, for example, I've had many patients approach me saying that, someone that's working for them's family member or someone, in close contact with that person that's working for them is COVID positive or is symptomatic, and that person has been in their home. And so that's a risk. I have other people that are, a lot of people are moving from San Francisco now to Marin County. I have several patients that have done that. They have a lot of people in their home, and I'm encouraging you as homeowners to go to your general contractor and have a conversation with them to figure out what sort of screening protocol they're doing so that they don't allow people to come into your home that are potentially infected. Clearly wearing masks is important, but also some sort of easy level of symptom checking. So even as minimal as, there are screeners that are available, they're ubiquitous, you can go online and find, that are basic screeners. I mean, the CDC has one as well that just it takes 2 minutes to fill out. And if they're positive, they have a symptom, they don't go to work. So I encourage people to set up some sort of a system of that approach. It sounds a bit crazy, but I'll tell you at Cavallo Point, for example, all the employees, they have to fill out a form every day before they go to work. Same with UCSF, they fill out a quick form and then they're allowed into UCSF. And I encourage that for all of us. So let's just spend a moment. I want to share some slides that Dr. Bree Williams shared at the UCSF Grand Rounds last week. She runs something called the Amend project, and it's really focusing on correctional facilities. She's done amazing work in this area, and I just want to share with you what I learned from her. So I've taken some of these slides, and at the end of this, if you're interested in this, if you're interested in volunteering, I've had several patients, wanting to know how they can help, how they can contribute and make a difference. And I'm really struck by the magnitude of the impact that they've really had. And this is one way to consider volunteering and some of the work that they're doing through the prison system. They're really focused on public health and human rights. And they sort of leveraging the Norwegian approach towards correctional practices to transform what's currently quite a toxic and unhealthy prison culture, and with the goal to optimize the dignity, humanity, and health of residents and staff alike. That's really their focus. And COVID-19 is really a moment where we realize that hundreds of thousands of staff that enter and leave jails every day, with over 2 million prisoners in our system nationwide. You've got staff that are going to work and then coming home. And here's another example of a population that I described where they can't work from home, so they go to their workplace to work. And that workplace in this particular situation is heavily populated. It's very difficult to do social distancing, and it can be quite a nidus for infection. And then they come home and it can infect their loved ones and others. So it's a big issue. If looking back in March, in California, there's 30 prisons as part of the California correctional facilities. There's 30 of them. There were very few cases in the United States in March, and now we have 70,000 cases with 700 deaths. 85% of those are related to the residents, with 15% related to the staff. And there's likely a lot of undercounting. So let me explain a bit what happened in San Quentin. 50% of the population is over 50. There's hundreds of folks that have significant risk factors. And so on May 30th, a whole bunch of folks were moved from a facility that had an outbreak in Southern California to San Quentin. They were screened, but unfortunately, a lot of them were screened a few weeks prior to their being moved. So they were screened negative, a week or two went by, then they were put into a bus and shipped up to San Quentin. Upon arrival, 14 of those 120 were positive. So on June 12th, they had 16 cases, and Ahmed was asked by the receiver to make recommendations about San Quentin's needs. And so their team went in on June 13th, and along with the folks from UC Berkeley School of Public Health. And they issued an urgent memo at the time. And it's calling for, the cells are 2 people per cell. The cells are 10.8 feet by 4.4 feet. That's how big their cell is, 4.4 feet wide, 10.8 feet deep, 2 people bunk bed in a cell. And the poor ventilation, these structures were built in the late 1800s, early 1900s. So ventilation was horrendous. The windows were welded shut. And everyone breathes into a common space. You can see here what the cases are. So if you look at California as a whole, 6.1 confirmed cases per 1,000. If you look at all the California correctional facilities overall, it was a lot, but 8-fold greater. And then you have San Quentin, which is 10-fold greater than that at 427 cases per 1,000 people tested. So huge outbreak. And what they found was, as they tested people over time, and they haven't tested everyone yet, you can see here, their test positive rate is upwards around 70% of the people they were testing were positive. And they have a total of what looks like about 1,600 cases at this point. Here it says 1,477, but when this was presented, the data most recent was 1,600 cases within San Quentin are positive. About 60 of those were hospitalized. There's many patients that need hospitalization but are refusing to go. They're just so afraid of the current system. These guys were scrubbing, apparently, according to one physician's testimony there. All the inmates were scrubbing their cells, and everyone was contributing to try and create a safe environment as best they could. But it was just profoundly complicated and difficult for them to keep themselves safe. You see even the staff, there's significant infections as well. So this has been quite an intense period of time in San Quentin. As a result of this, they've created an incident command center that was established at San Quentin, and it's led by the California Office for Emergency Management. UCSF is deeply involved. There's over 31 faculty that have volunteered now in the past week to help in San Quentin coming from UCSF. And they've really created they sort of created these recommendations, and now several weeks later they're engaging them, which is they're going to create a 100-person field hospital actually in San Quentin. They're moving people into tents and they want to try and get some people sort of out of the prison if they're about to be discharged anyway from the prison, or they're moving people into sort of creating more space by creating temporary housing within the within the prison system. This obviously, folks staff that actually are infected coming back to the community may serve as another nidus of infection for the community in Marin County at large, as well as the surrounding Bay Area. And as a result of this now, there's really a huge emphasis. I think there's 3 or 4 outbreaks going on right now through California within the prison system. So that's a bit of a detailed update. If you're interested in sort of this more, I encourage you to look at the Amend project. They're doing great work at UCSF. So switching gears a little bit, I wanted to spend some time really thinking about kids and schools. And the data is not out yet completely, but there's a mix of sort of conversations going on. The take-home message really is that young kids, seem to not be as likely to get sick, nor as likely to transmit that infection if they do get sick, or if they do get infected or colonized. And we think it relates to this receptor that sits on cells called the ACE2 receptor. And some of us are familiar with it because some of us are taking these types of medicines, ACE2 inhibitors, as a blood pressure medicine. And there was some concern early on that if you're on that medicine, would that put you at increased risk for getting COVID, which turns out to believe that thus far that's not the case. So it seems like there's less expression of this ACE2 gene in the nasal epithelium of kids, particularly kids that are under age of 10. It's elementary school. And then as we move to middle school range, it's a little bit unclear. The middle schoolers, it's sort of, they start to, some of them, I think there's a hybrid sort of a spectrum. As you know, kids mature in different times. So that's unclear. And then as they move into high school, it seems like they're more closely approximate adults. And so what's pretty clear in looking at the range of data is that it looks like K through 6th grade, there's very few people when they've looked at some of these outbreaks where the kid was the nidus of infection. Usually it was a parent or a staff member that actually was the nidus for a small outbreak. When they did contact tracing for kids that are under age 10, it was almost unheard of that child was the source case for the other people being infected. So that bodes well for thinking of K through 6, and of course with mask wearing and social distancing and all the things we need to do for schools. But in the case through 6th group, 6th graders, that appears to be relatively protected, in that they won't serve as a source of the nidus. Now this is very different from influenza. In influenza, they comprise 50% of the reasons why other people are getting infected. So when you close schools in the setting of influenza, it's a very effective tool for shutting down an epidemic. It looks like for COVID-2 that does not look like influenza at all for kids. So that is actually good news. And we'll see how things sort out over time. Several folks at UCSF, the pediatric group and the health policy group are working with California school system and others as well as locally in the Bay Area to really try and work using the science to try and figure out what is the best system. In brief, the thinking is that since schools don't even have enough funds for books and pencils and hand soap and basic things for hygiene and actually basic education, the approach is really a lot about social distancing, about wearing masks, and less about actually trying to disinfect the rooms. And because actually the biggest benefit you get is from hand washing, mask wearing, and social distancing. Granted, it's hard to get a kindergartner to wear their mask all day. So they're trying to work through some of these issues. All right. So I want to change gears a little bit and talk about therapies. And there's some interesting things to report since we last chatted. Hydrochloroquine, Plaquenil, shown to not be effective. And most people agree that this is not something that's been helpful, that there is some rare but a real risk of harm with what we call arrhythmias, or these irregular heartbeats that can happen from what we call QT prolongation. So whereas a shift in the electrical conduction of the heart as a result of azithromycin and hydrochloroquine, which are both medicines that can mess with that electrical conduction of the heart. And so there's the risk side of the conversation. And then what's the benefit side of the conversation? Looks like there's really no difference in mortality benefit when you compare folks taking this medicine against those that the control group, 26 versus 24% mortality. So really no change. And so most people at this point are saying there is no benefit from this medication and we should move on. On the other hand, there's this new medication, or it's an old medication that really costs pennies called dexamethasone, which is a steroid. And this medication was thought to be helpful sort of, in China, people were using it. And the long story short, there's some great research that's come out. It's a bit complicated, the studies, and people are waiting for the full manuscripts to appear. But it looks like folks that are requiring mechanical ventilation, which is what MV stands for, those that are intubated actually are showing a benefit up to 35% reduction in mortality. And those that require supplemental oxygen, so if your pneumonia is bad enough that you need oxygen, that you're getting a 20% reduction in death by using dexamethasone, a steroid. If you don't need oxygen, then there is no benefit. So if you have pneumonia or you're just sick, but you don't need oxygen therapy. So why is this? And the reason is dexamethasone is a steroid. So what is it doing? Unlike some of these other medications we're looking at, which are trying to attack the virus, this medication is focused on reducing our body's response to the virus, what we call this cytokine cascade or cytokine storm, where you have this huge response and you're sort of overreacting to the virus at this point in the body's attempt to try and rid itself of the virus and get well. So this steroid will dampen that response, and in so doing, help us heal and not kill ourselves, literally. So the sicker you are, the better the benefit, right? If you're intubated in the ICU, 35% benefit, great. If you need oxygen, you're that sick, you get a bit of a benefit too, about 20% benefit. So you move from a 25% chance of dying to a 20% chance of dying. So that's now sort of in the quiver of what people are using. The design of the study was a bit strange. And so we're waiting for really more details on the study design to make sure it was done adequately, because the way the study is designed, there's a lot of opportunity for this investigators to allow people to fall into other groups. So they may or may not have gotten a dexamethasone, or maybe the sicker people got it, or the less sick people maybe got it, or those that preferred not to be in that group got to choose not to be in that group. So it wasn't a pure design that was really simple to understand. It was quite complex. And so those that understand the science really want to wait for the full details. But it is exciting and it costs pennies. There's very little side effects to it used in the short term. So long term, there's lots of side effects, but in the short term, there's not. So there's very little downside to using this medication. So anyone that it fits these categories, in my view, should be given this medication. There's another therapy out there that we talked about earlier on, which is where you take the plasma from people that have been sick already, who have antibodies and other factors in there that to help the immune response, and then you give it to people that are sick. And what this is a randomized study. It was open label, so it wasn't controlled, placebo controlled, like you knew you were getting the medicine. That was a bit of the downside of this. It was a small study, and there's 50 some odd people in each group. But this showed improvement. Now, if you were super, super sick, it didn't show quite as good improvement. Again, that's because I think the overwhelming response of the body's own response of the cytokine storm really so overwhelmed any benefit that this medicine, that plasma could do. But if you're quite sick, severely sick, it actually showed benefit. So you could see here 91% versus 68% difference. And so that's a significant benefit. You're twice as likely to benefit from it if you had received the plasma. Also, what they found, which was interesting, is that people cleared more quickly the virus out of the blood, out of their body. So the more negative PCRs were seen 2 and 3 days after they received this medicine, which also was a good indication. So people are pretty excited about this, and we'll see more studies coming out, no doubt. So those are the current sort of really therapeutics that we're thinking about. There's more down the pipe that will be showing, that'll be coming up over time, but right now that's sort of the latest. So one question came up about whether I believe that hydrochloroquine could have benefit early on for early patients. There was another study looking at using it prophylactically amongst a whole bunch of health professionals, and that also showed no benefit. So a lot of folks, based on that study, are feeling like it probably doesn't work, at least prophylactically. Now, whether it's early on at the first onset of symptoms, whether there's a benefit in that group, that hasn't been, that I know of. I don't know of any data looking at that. But use prophylactically as sort of as you would for HIV, PEP, post-exposure sort of prophylaxis. That did not show benefit. All right, so what about vaccines? So yesterday, there was a publication in the New England Journal of Medicine, just yesterday, looking at this very, people are very excited about this current vaccine produced by Moderna. And this was a phase 1 study, so like the earliest phase in humans you can do. So this is where you sort of look at dosing and like what's the highest dose people can handle? Will I kill anybody, or will there be huge effects that we're concerned about, which are known as adverse events or side effects? And there's a dose escalation. So in this group, they had 45 people. They were, in the younger, healthier category, 18 to 55 years of age. And they got 2 vaccinations. They got one initially, and then a month later, they got a second vaccination. So these folks were in 3 different categories of dosing, 25, 100, or 250 micrograms. And so you had 15 people in each dose. And then they looked for how well their antibody response. And without going into too much detail, I will say that this vaccine sort of is an mRNA vaccine. So my understanding is this is pretty, Bernadita, you can provide, or Mary, some more input around this, but my understanding this is a novel vaccine approach that hasn't really been successfully done up to date, and this is the first attempt at using this. The advantage of this is you take sort of, and it's thought to be quite inert. It'll be easy to scale. The manufacturing of this sort of vaccine, and what they did is insert the S spike, so that the receptor binding domain, which is thought to be the most hyper allergenic. So you'll have the biggest immune response by showing this one little piece of the virus. And so they took that little piece that they think will jigger up the biggest response in our human immune system, and they put that inside this mRNA vector, if you will, and they bring it in and they inject it into the body. So then what you look for is an antibody response, and they saw as you escalate up by dose, you got a bigger and bigger antibody response. And then also they saw what they call neutralizing antibodies, which is the panel C here, the PSVNA, or neutralizing antibodies, which are thought to be the real warriors and to really provide that they do what the name describes, which is neutralize the antigen, in this case, the virus here, SARS-CoV-2. So you'll see here as the dose goes up, you see the scale go higher and higher, meaning that there's higher titers and higher antibody numbers, which is really good to see as the dose goes up and up. And secondly, you'll see that the neutralizing antibody response was also quite good in every single person that actually received this vaccine. Everyone had an antibody response, and those responses were equal, if not larger, than those that actually have become ill and have their antibodies as a result of natural illness through the course of natural history of the illness itself. So that was really quite promising. It's a small study. It's only 15 people per group. It's the first one. We need a lot more data, but people are pretty excited about this. You can see in on the far right panel of all these the convalescent serum. So that means people that have been sick, and then they take the serum and look at the antibody counts in there, and then you could see graphically that it was, for many of them equal and sometimes higher, the antibody counts from the vaccine response than actually people that were sick themselves. So then the other question, the real important piece around this is, what's the side effect profile like? And for the most part, people had tolerable side effects. There were 3 cases at the highest dose, 250 micrograms, where they actually had severe side effects. I don't know the details of that severity. You can see it here in yellow, or orange or yellow, depending on your color view. And you can see here any systemic symptom. You can see 250 micrograms. You can see in vaccination 2 on the second dosing that people had had a few people, I think it was 3 out of the 15 had a severe reaction. And if you look down below, you can see chills. It's a big one. Some people, one person had a headache, myalgias, some local reaction, and some people had severe erythema and locally at the site. So it'll be interesting to see how they sort of do the next phase of dosing. Will 100 micrograms, for example, be the sweet spot? So it's sort of a balance of how much additional benefit do you get, looking at the antibody neutralizing responses, how much additional benefit do you get from moving to 100 to 250, and then weighing that against the side effect profiles at the higher dose. So that's pretty exciting. That's most of really what I wanted to cover today, and what I wanted to, so please send questions if you have them. I'd love to there's lots of topics to discuss that I haven't covered, so please feel free in the Q&A or chat to ask some questions, because I'd like to welcome those. And while I'm waiting for some of those questions, I'll just mention to you a few different things. One is that I think it's real important now to find a balance. We talked about this last month, which is to really find a social group that's tight for you, and to really think thoughtfully about who comes into your home, and who you interact closely with. I think at this point, we have a big inflection point where there's a lot of illness moving through our community right now, and I think it's important that we act mindfully, recognizing that, until we get back down on the other side of the curve. So one question that's come up is, how safe is it to have people clean your home? Should we, and I guess the question is, doing dishes, doing laundry, etc. So I think people coming into your home is a risk. So, can you find a way that my suggestion is, number one, get a sense for what their circulation is, what's their living environment like, have an honest conversation with them about that their ability to earn a living is dependent on them staying healthy. So if they get sick, then they can't come into your home, and then they can't earn a living. And so I think it's real important that they have that conversation. And B, maybe they live with one other person, they live alone, or they live with 8 people in there where they live. If they live with 8 people, it's a problem, because you can't control what those other 8 people are doing. And then the other question is, well, what do you do? Do you want to test them and pay for their testing? That's an option. There's saliva testing, which is less invasive. It's $150. There's a sort of Avid ID test. It's a rapid test that insurance will often pay for. That takes a couple days. So those are options sort of pre-screen. It's hard to, it's expensive if you have people coming weekly. That would cost a lot of money to do on a weekly basis. But there's, I would just encourage you to think upstream. So that's number one, is how do I think upstream to prevent that person from becoming ill, and help support that. Many people have been paying for people, that the nannies or people that are cleaning their homes or what have you already, even though they haven't worked for them for months. So if you took that, if you think about that money that you've already contributed to it, and then think about, well, how can I justify spending more if I can afford that to get them tested, or is there a way from there for them to pool it amongst their other people's homes that they work for, so that they can pool that resource and get tested, and then minimize their own risk and just have an honest conversation about that. So then when they come into your home, you know, ideally you help them learn how to be sterile, or, you know, reduce risk as much as they can. What does that look like? Ideally, you're not in the home when they're in the home, or you're in a different part of the home. You have the windows open, so there's good ventilation in the home. They're wearing a mask, obviously. They are wearing gloves, or they come in and then wash their hands is the first thing they do. You sort of observe them wash their hands in your home. They're wearing a mask. Then they clean your home. Windows are up. Lots of ventilation. Fans are on. That dramatically reduces risk. I think the fomite risk is low. Like, they touched your counter and now you touch the counter and you now going to get sick. It's much more likely to happen through the air circulation. So thinking about ventilation and air circulation is how I'd approach it. So they clean your dishes, sure, I wouldn't worry about it. Doing your laundry, I wouldn't worry about it. It's really transmission through the air, is how, you know, other than sort of direct contact with you, is how I think it through. Any other thoughts or questions? The other piece I would just encourage you to think about is, from what I said in the beginning, is really taking this time to have a daily practice and find your own space. Use this as an opportunity for you to recalibrate what's important, and who the people you want to spend time with in an intentional way, as well as being thoughtful about, you know, really getting enough sleep and sort of creating the healthy habits, because a lot of people are, at this point, they can diverge. You know, you can start just feeling more isolated, feeling more pessimistic. There's a lot to sort of, you know, feel down about at this point in time. And then we tend to eat more and check out more by watching more TV, and then we go to sleep later, and then we wake up not feeling well and not rested, and then we don't want to exercise, and so things start to unravel. And for your own sanity and quality of life, I feel it's important to think that through, let alone your risk for getting infected as well from this or any other illnesses that will come to pass. So I encourage you to try as best you can to really have a daily practice that, you know, lifts your spirits. There is a lot to look forward to, in that. I think there's good news around the vaccines. I think there's good news around the politics of where we're going to be in January. My personal biased partisan opinion. And so I think if we can keep ourselves focused on the positive, that would be our best way of moving forward. Well, thanks everyone for your time. We'll do this again in 2 weeks, and hopefully we'll have a lot more information to share as more and more of the science is coming to the forefront. And hopefully we'll see in the next 2 weeks that there's a decline in new cases in your region, and that we start to get a sort of a grip on what's going on. So I think things are promising, and that we're finally seeing, you know, the southern states themselves also stepping up and saying it's time to do the right thing by wearing masks and social distancing and all that. So I think it's really positive. So keep that in mind, and I wish you all well. Until next time. Thanks.
Take care.